Hi, I'm Amy Price, and I'd love to welcome you to our very first PxP conference. And this is a conference that is built for patients and by patients, but of course, everyone's welcome. And our first conference is all about patient engagement and research. I'm actually privileged to be a member of the International Steering Committee, and I have just witnessed how it's been completely designed and developed by patients for all aspects of the conference. And Dawn and Hetty are going to drop a link into the chat. They're working behind the scenes about our steering committee members, so you can find out a little bit about us. And there's also links to resources that we think would be great for you to take a look at later. So make sure to save those links. And so, first of all, I want to share I'm broadcasting personally from Florida, and I would like to share a land acknowledgement. And this is something where we're joined together by people from across the globe, and almost all of us, the land that we're living on today has been stewarded by some Indigenous people for thousands of years. And oftentimes they're forgotten. So we just want to take a moment and remember and recognize our heritage. So I'm joining from the territory that we now know as South Florida, which has been the traditional homelands of the Native nations, including the Tequestra, the Cahusa, and today the sovereign homelands of the Seminole and Muskogees. And so, because we're an international conference at PSP and we're virtual, some of our attendees, almost all of you, may not be familiar with this practice. But we encourage you to spend some time learning about and reflecting on what a land acknowledgement means. And also, please take the time to share your land acknowledgement in the chat if you would like to do so. We would like to honor all the people that are here. And again, there'll be a guide posted in the chat to share with you how, and just to let you know who's with us today. We have people from Argentina, Australia, Austria, Brazil, Canada, Colombia, Denmark, Ecuador, Greece, France, Ghana, India, Indonesia, Ireland, Israel, Italy, the Netherlands, Nigeria, Philippines, Portugal, Romania, Singapore, South Africa, Spain, Sweden, Switzerland, Trinidad and Tobago, the United Arab Emirates, the United Kingdom, and the United States. And there's probably some of you that have joined. And if you're not on this list, please put it on the chat so that we know where you've joined us, from. And we'd like to do even like a quick poll before we even get started, and we'll be doing that in a moment. Just asking who you identify with. Like, do you feel like you're a patient partner or a caregiver, a clinician? And Hetty is going to put that on the screen. But as we're getting that ready, let's look at just a couple of housekeeping notes. So we're going to have 3 sessions around the theme of building your skills: the what, the why, and the how of patient engagement in research. There will be 30-minute breaks between sessions. The first session is an introduction to an overview of research. The second session about resources that can help you with your skills as a patient partner. And the last session is about mentoring and being mentored as a patient partner. So these are all like so critical, and what our steering committee and people focused on the things that were most important to them. So I want you to use the question and action answer function of Zoom to ask questions of the session speakers, and we'll try to get as many questions answered as possible, and then use the chat function to share a bit about yourself. So they're kind of side by side. One will say chat and one will say like your questions and answers, and share any resources you'd like people to know about from your end. And Hetty will be posting a Zoom guide. And remember, use those Zoom emojis to share your reactions with panelists and speakers. and each other in real time. And if you want closed captioning, which sometimes it makes it easier not to miss something, so I always like to use it. And it's available to viewers who join the session. Turn this on by selecting the CC button at the very bottom of your screen as a viewer. You can then select the language you would like these captions to appear in. And I'm not going to spend very much time introducing our speakers. We'll ask you to look at the conference website to read more. And our social media hashtag, and this is how people know we exist, is, the number symbol PxP 23. So PxP 23, and feel free to share anything you wish on social media. And please know we are recording all sessions, and they will be posted on the PxP website after the conference so people can watch who couldn't join. So while the conference has been designed for and by patient partners, we welcome everyone who has joined us. We believe in an everyone included mindset, and we need each other, and we are as strong as the amount and the diversity of people and of roles that we have joining us. And I would like to take this time especially to welcome our conference's supporter and to be thankful. So this was the brainchild and the financial support of the Canadian Institutes of Health's Research Institute of Musculoskeletal Health and Arthritis. So before we get started with the first session, and we're getting you, we've done this simultaneously with the poll, and you brought your perspective. So let's just take a moment to share them. So what we're seeing is 68% of our viewers identify as patient partners, 20% as caregivers and relatives. We have 10% of people that identify as a clinician, 35% as a researcher, 5% as trainees or students, and those who are interested in learning more about patient engagement, 26%. And in case you're wondering, you're saying, hey, that's way more than 100. That's because some of us are patient partners and researchers, or caregivers and clinicians, or patient partners and students. And of course, we're all learning and want to know more about patient engagement. So let's go now into our very first session. And I'm the moderator for this session. And this session is setting the scene for the PxP conference and building sustainable partnerships. And this is critical because it's fine to have a partnership, but if you can't have a partnership that transcends time, tragedy, joy, financial collapse, financial blessing, and all those things, then you don't really have a sustainable partnership. And so we want the kind of partnerships where people are with you no matter what, and that people have your back. It's a safe place to contribute, and that you also can be that kind of person that can reach out as a community. So a public contributor and researcher perspective will be shared by Angela Ruddock and Shoba Dawson. And Hetty's going to play their video. So they did this ahead of time so that they would be relaxed and ready for your questions and answers, because they're live. They're right here with us now. And let's take it away.
Hello, my name's Angela Ruddock. I'm a public contributor, and this is my partner in crime, Shoba Dawson, a researcher.
Thank you, Angela. So what we are going to be doing today, everyone, is that Angela and I are going to take you through what researchers, who does research, some nuts and bolts of public engagement, followed by sharing the importance of building sustainable partnerships. And then last but not least, Angela will share her research journey with you. So to begin with, what is health and care research? So this basically focuses on looking for new information, understanding and exploring the existing evidence to improve health for everyone. There are different types of health and care research. So for example, you have public health research, which focuses on improving the health of the society as a whole. So this can focus on various factors such as environmental, genetic, and social determinants of health. So for example, it can focus on interventions such as pollution or placement of food in supermarkets, or it can also look at transport and traffic related initiatives. Then we have social care research, which is about improving the lives of people who receive care and support from social care sector as such. So this, for instance, could focus on mental capacity of an individual and looking at personal finances, supporting parents with learning difficulties, topics related to adults with dementia and their carers, etc. Then we have basic science or biomedical research, which is about understanding how every part of the human body works. So this focuses mainly on cellular level, organ systems in itself, and whole body as such. So essentially, biomedical research leads to new ways for diagnosing, preventing, and treating various illnesses and diseases. And then last but not least, we have trials, and trials can include various interventions, and these can range from diet or exercise related to testing the effectiveness of, for example, a surgical treatment or even medicines. So looking at clinical trials specifically, as I have mentioned to you in the previous slide, so this can, for example, look at how safe and effective a particular medicine or treatment is, and it can also include interventions such as use of a particular terminology. Quite often, clinical trial involves comparing one treatment to another to see which is better. And through this process, it allows us to explore any side effects and try and weigh them against the benefits really. And generally, medicines have to go through a clinical trial in order for them to be prescribed. And this then allows all of us to identify what the evidence looks like in terms of how to give a medicine safely, and adds to our knowledge about a particular treatment for a health condition. So there are other types of studies as well in addition to these. One of them is population-based study, which involves following the health of a large number of people for a number of years as such. So this type of research typically focuses on social, cultural, environmental, or economic factors and how they affect the health of individuals or people in the society as such, and that could be for better or for worse. These can be done in the form of questionnaires, interviews, or focus groups, and they can either be one-off or done on multiple occasions over a period of time, and that mainly depends on the needs and purpose of the study itself. So who does research? So research can be done by clinical people. So this includes doctors, nurses, consultants, or non-clinical people like myself who are like health researchers, or you can have psychologists, sociologists, etc. Or it can be trainees. So these can include medical students or undergraduate students or pre-doctoral students who are, these are individuals who are yet to undertake a PhD. Or it can be by someone with or without a PhD as a researcher at research associate level, or people who are doing their PhDs or have just completed their PhDs at postdoctoral level, or as research fellows or senior research fellows, similar to me, who have had postdoc experience and have moved away from that. Or you would hear terminology such as principal investigator or co-investigator. So principal investigator is someone who's often responsible for the conduct of a research project as a whole. And a co-investigator is someone, either the co-investigators or collaborators often contribute significantly to the development of the project, but they are not on the equal footing with the principal investigator. So there are various terminologies really. So these terminologies include involvement, participation, engagement. Quite often, at least in the UK setting, they are used interchangeably, wherein they either mean the same thing or sometimes they mean different things, yet they are still used interchangeably, which is not very helpful at all. So in the UK, involvement refers to patients or members of the public that are actively involved in research, including designing research studies. Participation refers to taking part in research studies by completing surveys or interviews or providing samples. And engagement refers to sharing study findings with wider audience, which can include patients or public, healthcare professionals, and researchers. So again, in the UK, we refer to public involvement or patient and public involvement, wherein in Canada, US, and in other parts of the world, it's often referred to as patient or public engagement. So public involvement to us means research carried out with or by members of the public rather than to, for, or about them. In Canada, the Canadian Institute for Health Research defines patient engagement as meaningful collaboration, wherein patients become research partners or patient partners in a project and can be actively engaged in different stages of the research process, including the governance, priority setting, developing the research questions, and even performing certain parts of research in itself. Quite often, these are mandated by funding bodies across the globe to ensure that research is designed with input from those who are actually impacted by it, and actively engaging with patients and the public has the potential to improve research quality, relevance, impact, and integrity. So in terms of who gets involved or engaged in research, again, there are various terminologies. These are often sometimes used synonymously or interchangeably. Other times, depending on the context, different terminologies are used. So quite often, for example, consumer or service user context is used in relation to a healthcare setting, wherein anyone who uses the service is seen as a service user or consumer as such, or even citizen for that matter, as it is labeled or described in places like Australia, etc. In UK and Canada, etc., we often refer to them as patients or public. And then you also have collectively engaging and involving the community as a whole. So I'm going to take you through a continuum of engagement in research as such. So this basically can, sit in a spectrum wherein there is literally no involvement to research being led by the community or the patients or the public themselves. This can be community informed or focus on consultation with community, so can happen at a very superficial tokenistic level where often the power and control and ownership lies with the researchers, and that's where researchers' responsibility lies as far as decision making is concerned. Then you have community participation. Again, people are only taking part in the research process, and those who are impacted by that particular topic area aren't involved in any other way at all. And then you have the other end of the spectrum where research is initiated by the community or the certain groups of patients or public themselves, wherein the decision-making power, control, ownership, responsibility lies with both patients and public and also the researchers. And then you have a very collaborative way of working where power responsibilities are shared between the researchers and the patients. It's known as community-based participatory research. And then the other end of the spectrum is essentially community-led or community-driven research, wherein they hold the power, control, ownership, and responsibility for decision-making. What is quite important and crucial is to ensure that the research work that is undertaken is mutually beneficial and benefits both the parties involved, i.e. the researchers and the community. Of course, a lot of this depends on various contextual factors as well in terms of whether we have existing or established links with the groups at all or not. And we also need to ensure that, it's a mutually respectful relationship and there is transparency throughout the process. So thinking about the stages of the research process in itself and how we can engage patients and public in it. So the first step is that of the prioritization aspect, wherein we involve or engage with patients and public to suggest topics for research. Then comes the research design phase, where you focus on clarifying the research question. And then comes the development phase, wherein you ensure that the methods are all ethical and reliable. Then comes the stage where we focus mainly on the recruitment side of things as such, wherein we get help from patients and the public to write patient-facing materials and consent forms, and then analyzing and interpreting of study findings, wherein they can help inform researchers how to interpret those findings, followed by dissemination, which includes communication of findings to different audiences. And then it's about translating those findings into practice, which is the implementation phase. And lastly, it's evaluating in terms of working with researchers to identify what worked well, what didn't, and what can be done differently. So as I have already mentioned to you, engagement does not always equate to co-production. By co-production, we mean that researchers and the public work together, share power and responsibility from start to end. So it's not just doing it for certain stages of the research process, but throughout the research process. So for example, within the UK, we have something called as the Co-Production Collective, wherein they are essentially a co-production community where everyone is welcome, and together they work together to learn, connect, and champion co-production for lasting change. If you're interested, you can go through their website. They have a lot of resources which you might find helpful. So another thing that is also very UK-centric is we have a website developed by our funder, National Institute for Health and Care Research, NIHR, called People in Research, wherein it allows researchers the opportunity to advertise involvement or engagement opportunities and recruit people through these routes. And then similarly, anyone who's interested in becoming involved or engaged in research can go through this website to identify relevant opportunities. That said and done, I'm quite aware that this is something that is very specific to UK, and it doesn't necessarily exist in Canada, US, or other parts of the world. I'm going to stop here now, and I'm going to now pass it on to Angela to provide her perspectives. Angela, over to you.
Thank you. Okay, well, I'm going to give you my personal account of my journey as a public contributor. First of all, I thought I'd just tell you a little bit about my background. I'm now a retired grandparent. My principal role is that of childminder for 2 grandchildren, even though I never saw myself as doing that. I'm now well past middle age, although I'm told that I don't look it. I often feel it, I have to say. And I've always worked full time in the past before retiring. I took just 2 maternity leave breaks, so I know what working full time actually means. Then, as I got older and as my children got older, like many people I know, there are issues around our own parents that we had to think about as they became less mobile and in need of care. So I became involved as they became less mobile and began to have various conditions where I was in some roles acting as family carer. So, next question, why did I become a public contributor? Well, I think, again, in common with a lot of people who get involved in health research, my interest began when I began to experience family issues. with the care of one of my parents in particular, and that's when I took a keen interest. Um, there's we have a couple of conditions that are prevalent in our family. First one was diabetes, so I became particularly interested in that as older members of the family developed that. I was increasingly becoming involved as advocate, if you like, for my mother before she died in 2015. And as she got older and more frail, she was developing multiple long-term health conditions. And I was involved both here and when later she uh, went back to Jamaica, I was involved in navigating areas of the health service that she needed. The GP service, mental health services, as she began to develop dementia, and obviously talking to hospital consultants. So when I retired from full-time work, um, I could devote more time perhaps in health research. So the first thing I did when I got involved in that and began to hear about it was the diabetes research group, which was attached to a local hospital. And then I met somebody who suggested that I might want to join a group that's perhaps got broader interests, health interests, um, and it was mostly within the area of primary care. And I've been a member of that group ever since. So again, like many people I know, I've spoken to, it was almost by accident that I became involved because these things aren't advertised, are they? Um, so I I began to develop a better awareness of research, um, and I wasn't didn't just imagine that these roles were as just as participants, or my mother used to say, guinea pigs. That is when I became engaged and very involved in health research. So, um, I suppose we're talking about over 10 years ago. The traditional public contributor role that I had was as described, I think, by Shoba in the first part of that cycle, where I was very much involved in providing advice on patient-facing literature, working with researchers in listening to, contributing to health research topic, providing advice and guidance from a patient perspective. Um, Very much involved in writing what were called plain language summaries so that they were reasonably understood by members of the public as opposed to other clinicians. Um, and I worked um, as a PCI collaborator on a number of projects um, and as a member of a patient public advisory group for a number of projects. So, um, one of the issues I think that I'm interested in raising now is looking at how the public contributor role has devolved because and developed. When I first joined as a contributor, and I could sort of look at the group of colleagues that I was working with, what was reflected back to me was very much the equivalent of what's called in the UK the Women's Institute. They were very usually very educated, very middle class, female, very old from my perspective. When I was in my 30s, I thought they were very old, and also, unlike me, very white. Um, this has moved on since I started working in research, and I've seen some real changes, and certainly an increase in diversity um, in terms of public participation. Although, I recognise there are still real challenges that are facing us. The interesting thing is we used to talk very much about hard to reach groups, um, when the reality is, in my view, it was the other way around. Universities, clinicians, academics can often be seen by the communities at large as hard to reach, rather than the other way round. And we needed to think in terms of how we could actually make um, these things a positive experience for people who perhaps past experience of education has not been as positive as, say, maybe mine was, or others. So even the sort of layout of the university buildings, the huge halls, the labs, um, very much reflected and sort of intimidating academic approach, like an ivory tower almost. And I think we've certainly worked through recognizing that these aren't the best ways to encourage people. And we've looked at where more welcoming approaches in terms of physical settings, in terms of language, culture, and age appropriateness. There's a whole range of things that we still need to do, but it certainly moved on from my initial days working as a public contributor. Now, there are a few examples that I wanted to give of the types of specific involvement I had. Um, First of all, I suppose I'll just give you two examples. The first experience I had was where I was working with a qualitative research team looking at and examining behaviors and lifestyles of patients who have diabetes type 1. And these are what we identified as successful um, diabetes patients who had managed successfully to control their blood sugar level, and examining ways that they've actually done that. So this involved, from my point of view, some training for me in order to ask the questions, ensuring that I was consistent, ensuring that I could draw as much information out of them as possible, um, about their background, their lifestyle, the support that they received from health professionals and their family, both positive and negative. And I was very surprised and somewhat pleasantly surprised at how candid and straightforward their responses were. Um, Virtually in every case, and I think there must have been about 18 or 19, I think, people that I uh, was interviewing, they felt more comfortable giving their views um, to a fellow patient or member of the public, rather than a clinician, because they felt they could be honest. And because there were some bad experiences they had, as well as good experiences, but they felt more comfortable giving that. So I felt that that was something I was able to perhaps, develop more. It made me wonder what vital information researchers may be missing um, from the public, and what perspectives we could actually contribute to improve and enhance the sort of research work that's going on. So this involves looking at preconceived ideas and challenging them, I suppose, with researchers. And that was quite illuminating, I think, on both sides. The second area that I was involved in is when I actually worked with Shoba in looking at a specific South Asian community who historically has had very little involvement with research, um, mostly women. Um, these This involves identifying the community, looking at the background to previous research in the area, looking at surveys that had been done before, talking to focus groups, talking to individuals, anonymized interviews, that sort of thing. Again, that was quite detailed work, so quite a development for me. And again, there was so much rich evidence of how sections of the community are either selecting themselves out of research because they feel that they haven't got anything to offer, when in fact they had so much to offer, and either selecting themselves out, or they've been ignored by the community because of language, culture, or status of the research community. So I think those were the two examples that I wanted to give. If I can sort of move on now to the area around public contributor versus community. It's two issues that have come up, I think, more recently as the whole business of research has been developed and people are looking at the roles of the public contributor and the roles, as Shoba has described, of community voluntary organisations that may have a particular interest in certain groups or certain conditions. I think the question has come up as to whether there's a role for either or both, or are they mutually exclusive? This is something that that has challenged me, I suppose, as well, because I obviously come from Black Caribbean community. And my background is from London, and I've been dealing with working with people who are considered to be one community, but there are all sorts of differences and issues that we have to consider. So no one person represents one group. So there are issues around gender, issues around culture, issues around age, and all sorts of behaviours around that. So I feel that we both have a role to play in ensuring that as much information and as much dialogue takes place, both with individuals, if you like, individual public contributors, as well as community organisations. So I personally have developed my own knowledge in getting into grips with some of the various issues that face that particular community. And believe me, there's no such thing as a homogenous community anywhere. The second area, which has been a really big challenge for me, as I am not particularly numerate, is working with big data, as we call it here. So we're looking specifically at population research, particularly since COVID. That's something that I have been involved in, where we've been looking at quite big figures, big numbers, where populations have been affected by COVID, for example, but for other things as well, where multiple long-term conditions, that sort of stuff, where we're looking at differences that are reflected by regions, class, socioeconomic status, certain cultural underserved groups that have been affected. That, to me, has been extremely eye-opening in terms of the information, but it also, whilst being very quantitative, does require an input, if you like, from the groups who are actually the results are actually being discussed, because there are so many things, so many individual facets that can change and that can affect populations, and it's important to have that discussion. So it's been a learning curve for me in terms of looking at, I'm going to use this word, which I have real problems with, epidemiological effects, in population research. And it's something that I think that individual members of the public tend to struggle with, but we have to recognize that we're not here to actually identify the statistical terms. We want to see the effect that these things have and talk them through, and that's the role that we play. So that's been a particular challenge for me. I think the other thing that I wanted to talk about was what I find particularly satisfying. What is in it for me? I mean, clearly it's not the money because the um, um, the payments are not at all great. It's just an honoraria. But I think in particular, there's a personal satisfaction actually knowing that you are hearing and learning about research and understanding things that perhaps you may not have had the clear understanding of why things are done in certain ways and how groups respond to different things. And also the fact that you know you can add to that information that I'm thinking of various examples where I've actually had a discussion with a researcher who may not have realized that somebody who is a single parent has got 3 kids and has to, prioritize her work may not be able to say as much about the symptoms of her mental health than somebody else who perhaps doesn't have has more time or less things occupying their mind. So I think it's important that they actually see a variety of perceptions, a variety of views, and I feel I'm in a position to give that, and they actually value it. They value the information. So I feel that I'm able to sort of contribute to future and positive change. It's all about self-worth, isn't it, at the end of the day? And if you feel valued, if you feel that what you're actually giving is of worth something, then it's satisfying, it's extremely satisfying. And certainly I've been doing this now for over 10 years, so there must be something that I'm getting out of it that I'm enjoying. So I think it's the issue of being valued. Lastly, I want to talk about just reflections based on my experience. I never thought of myself as being an old hand at this. I always thought of myself as a new girl, and I was always thinking I needed to ask other people's opinions. And now, of course, people are doing that to me. But I feel that there's been a personal development for me, from being a novice um, to um, a public contributor who is gaining in experience and can now ask questions in ways that I hadn't been able to before. And I am raising issues that a researcher may not be aware of. And certainly in terms of a whole range of things, I feel that I've been able to do that. I've received quite a bit of training, both formal and informal, in terms of design, questionnaires, understanding the difference between different types of research, and looking at how one can look at groups and know that there are certain groups that there'll be different groups, but they'll have lots of things in common. The word intersectionality is a word that is used quite a lot these days, but I firmly believe that looking at you're looking at different groups, you're looking at all the issues that they present. There are some common features. They're expressed in different ways, and they're all valued and they're all important. And that's something I felt that I've gained in all these years. I think also as we have developed in ensuring that the contribution is from a diverse public, we should not be tokenistic around this. We have to recognize that I don't represent, for instance, the whole of the, you know, Black Caribbean community in Manchester or in London. Um, that I am one person with one voice, and I've had different experiences, and they may not be the same as another person, but it's a view. But if you've got lots of different views, I think the research is going to be much richer as a result. And that's what I feel I have sort of gleaned in my experience. Okay, it's not just a tick box exercise. So I think that's it. Thank you very much for listening, and hope we can have a good discussion after this. Thank you.
Thank you all for listening, and thank you, Angela.
Thank you so much, everyone. So now we're at the amazing place. There's been a lot going on in the chat where we'd like to ask our speakers questions. So if you can put your questions in the thing that says Q&A, and then we'll send them over to our speakers. So we have one from Linda Hunter to start off. And this question is for Angela. How involved have you been in co-authorship and publication about the research you have been involved with?
That's an interesting question. I think this is one that I can honestly say there hadn't been as much involvement when I first got started within health research. It's only, I would say, in the last, 3 years where the issue had come up and very much reactive. But I've had two situations where we've actually been involved in forming the question, forming the sort of research study. They're difficult because I recognise that there are power issues around this, and one of the issues that I felt we need to get to grips with is power, resources, and allowing, if you like, or giving the opportunity for public contributors and communities to actually control and decide what is important to them. So the short answer is I haven't been, but hope to be doing more in the future, as I have been doing in the last year or so. Hope
That's
that
great.
helps.
That does help. But that's something that we've been also trying to promote at the BMJ for years. And I remember we don't really realize sometimes how far history has come, because I don't know, 12 years ago, you couldn't convince a journal to take a patient author because you couldn't name their institution. I mean, or their email didn't have an edu or something. There were so many even just technical barriers. So we have come a long way. Shoba, and you also wanted to share something on that.
Yeah, so from my PhD, we co-authored a paper with both Angela and another PPI contributor, but the whole process of submitting that paper to the journal Research Involvement and Engagement was a challenging one, because they expect everyone to have some sort of affiliation, which is not very realistic at all. And not everyone wants to share their email address either, because you then get bombarded with a lot of unnecessary emails, which is not what everyone is signing up for either. So there is trying to strike that balance as well.
Yeah, that's a really good point. And Dawn, did you have something that you wanted to share on that area? Dawn's done a lot of work on this.
Hi, everyone. I'm in the background supporting, but Amy, thanks for pulling me in. I support what Shoba has said here, that for those who are in the publishing business who are out there, take note. It's difficult for patient partners sometimes just to be involved in the processes, but it's also important for the researchers and clinicians to know that individuals like Angela and others can certainly bring intellectual contributions that make them eligible to be authors. And I think it's just an interesting experience when you do work with a number of patient partners to write a paper. It's going to be really different than if you didn't have their perspective. So like you said, Angela, having multiple perspectives really brings a beautiful product that people wouldn't have had otherwise.
And Stella has a question for panelists and our speakers first. If you had powers for a day, I mean, we would hope we'd be longer, but let's just say a day. What is the single change you'd wish to see to achieve through true PxP, or like patients and partners? And
Gosh, who are you asking the question?
all of you, just like, okay, so Angela, let's start with you since you asked me back, and I'll answer, and then let's go through and see what we think.
Oh, I think I just my first view is I look at, for instance, how much is actually spent on a project. I'm involved in quite a number of research submissions where they have to do a proper costing exercise of what that research will cost over, say, I don't know, 3 years, 4 years, 5 years. And it's quite a big cost, in terms of the proportion of salaries, um, the equipment, the consumables, a whole range of things like that. And my wish is that wouldn't it be good if people actually could quantify, if you like, the need for input from the patient partner. We have a certain formula, I think, in England, in the UK, of how much a patient partner should get, that sort of thing. But I think if we use the same approach that we use for itemizing the use of secondment of researchers and looking at computing equipment, looking at various things like that. We probably end up spending a bit more, I think, on patient carers, on all the various things that we need to attract patient carers, background support, interpreters, translators, decent environment for people to actually meet, investment to actually meet on a regular basis, not just about one subject, but understanding, if you like, the background of that community and where they're coming from. And I think we'd have better engagement, better understanding, better contributions from the communities and from individuals. That's my wish. Probably probably too big a wish, but I think if we had a bit more understanding of the investment that would pay off, with greater in-depth and long-term development projects, if you like, with communities, we would get far richer results, valuable results, and valuable input.
I mean, I think that's great. Like, as a student researcher, I looked at all the funding that went to public and patient involvement and how much the patients partners actually got, and it was stunning, the lack of funding. And I've seen that that's growing, but there also has to be provision for, if you're not allowed to take an income because you're on some kind of
benefit,
like some kind of social system where it gets cut off and you'd have to start all over again. So you might as well die rather than take than take a something. And if there could be some way that could be passed on, that could be given another way, so that those contributions are valued. Like I and where patient partners could choose to be the giving part, not just say, oh, well, you're not going to use it. We, the researchers, or we, the clinicians, will decide what is done with the dollars that you didn't spend. No, let patients decide for themselves. So I'm with you. There's a lot that can be done with, I think the other thing that I would do is I would dismantle the hierarchy between clinicians and researchers, because it puts in place an artificial hierarchy between researchers and patients, and between clinicians and patients, and it doesn't allow people to be who they are. And again, I think this is getting better. I've wished for it for a long time, and so I'm up for that. Shoba, would you like to share on this?
In relation to the powers, if I could, I'll ensure that only studies that are truly collaborative, that shows that it's been developed based on the needs of the community, would get funded, and nothing else would get funded. If I could, I genuinely and honestly would do that. And that's one of the things I've been trying to discuss with various funders, organizations, etc. But sadly, we still have a long way to go. One of the things, Amy, following on from what you just said, when I started my PhD back in 2013, which is how I met Angela, my PhD project didn't have any funding for patient and public involvement or public engagement, as you call in Canada. So one of the things I did was, because it was part of an existing infrastructure and my main supervisor was the director of that, I ensured that I did a spreadsheet of costings that I needed throughout my PhD for PPI, and I involved Angela and someone else at the beginning, and then for various reasons they dropped out, and then I managed to recruit another individual. So this paper which we talked about, it essentially has got me, followed by Angela, Veena, who was the other PPI contributor, and then my supervisors as co-authors, where we have essentially described our journey of working together throughout the PhD project, really. And the reason for doing that is because a lot of upcoming young researchers don't really think about doing PPI at all within their doctoral research or even pre-doctoral work. And that's something I've been trying to champion as much as I can. So currently a PhD student we made sure she found some funding to do some PPI work within her PhD as well. And I think funders need to start doing more and more of these type of things as well, and encourage people to do PPI throughout and not just tokenistically.
I love that. I love that. Like we're at time, and so I just wanted to say we're going to be joining again in 30 minutes. So feel free to either reconnect or just turn your camera off, take some me time for 30 minutes. And just to add, it's so important that we show people, students, new researchers, everyone, how to involve patients when you don't have money. What do you do instead? What can you do instead? How can you make people feel welcome? And how can you set the stage so that you can bring them in and get funding for them as you're going along? And I love that Shoba's now doing this with her students. That's incredible. And thank you so much for being with us. I'm so honored to be a part of the hosting for both of you. And I wish you every success on your continued journey and the children of research that you will bring into this domain. Thank you.
Thank you.
Thank you.
Okay, so we're all going to take the questions that weren't in your answered. We will try to answer them and get some responses to you. And thank you so much for being engaged, and love all the excitement in the chat. Bye-bye.